Hello, everyone. I am Dr. Julius K, and I'm super excited to be presenting to you today on total hip replacement periprosthetic fractures as part of the Arthroplasty in Africa conference presented to you by the Harvard Global Orthopedics Collaborative and also the Global Orthopedics at Johns Hopkins Initiative. It is especially a pleasure to be presenting at this conference because my inspiration to go into joint replacement as a specialty was my paternal grandmother who had end-stage arthritis of bilateral knees and needed knee replacements, but there was no one to do a knee replacement at that time. So at that time, as a third-year medical student, I decided to pursue a career in joint replacements, and now I get to replace the knees and hips of other folks, grandparents, fathers, mothers, uncles, and aunties. And so this is a really special conference for me to present to, and I hope that you will get some value from this presentation. We will be talking about periprosthetic fractures of the hip. And so let's dive right in. This is my disclosures, and none are relevant to the topic being discussed in this particular presentation. So we will be talking about the acetabular periprosthetic fractures and femoral periprosthetic fractures. Let's dive right into the acetabular fractures. The vast majority of these acetabular periprosthetic fractures are rare, and we will discuss them as intraoperative, early post-op, or late post-operative. They're usually less than 1% of cases, and they usually occur during the insertion of the acetabular component. Historically, the incidence of acetabular periprosthetic fractures are less than 0.07%. However, we do think that they occur probably more frequently, and that their estimated incidence is actually more, probably around 1 to 2%. But most of them are unnoticed because people are putting screws in and you just don't notice them. But if you are operating on a rheumatoid arthritis patient, you probably should have a high index of suspicion for acetabular periprosthetic fracture intraoperatively, because there's a higher incidence in those patients, given the poor quality of bone in those patients. For postoperative fractures, the incidence is pretty rare. And once again, the incidence of about 0.0% is 0.07%, so less than 0.1%. And there are some small case series reporting this in the postoperative period. This is some risk factors associated with acetabular periprosthetic fractures, particularly underreaming underreaming by greater than 2 millimeters, or elliptical modular cups. We'll discuss that. So pretty much with the elliptical modular cups, the reams of those cups are wider than the rest of the cup, and that usually increases the risk of peripheral fractures of the wall. Obviously, osteoporosis will also increase the risk of fractures. Cementless acetabular components will increase the risk of fractures compared to cemented acetabular components, and those other risk factors as listed there. Once again, press fit technique or cementless acetabular components are going to increase the risk of intraoperative fractures, particularly if you are underreaming by 2 millimeters or more. With 2 millimeters of underreaming, you increase the risk by about 13%. And with 4 millimeters of underreaming, you increasing the risk by about 54%. So that's significant. That's why the vast majority of us would only underream by about 1 millimeter, or in most cases, with elliptical cups, you would just ream line to line, which means you ream in a 56 reamer for a 56 cup for most elliptical cups. For hemispherical cups, most people are hand reaming by 1 millimeter, which means you're reaming to 55 millimeters for a 56 cup. And once again, you have to be very careful and understand what type of acetabular component you're putting in. If you're putting in a very stiff acetabular component, like most of the cobalt chrome cups, those will be at higher risk of causing a fracture versus more of the titanium cup, which is closer to the elastic modulus of close to the Young's modulus of the bone. Once again, if you eccentrically ream and thin out either the posterior or anterior wall, maybe because of limited exposure, that could also increase the risk of fracture. And if you over ream medially, that could also increase the risk of fracturing through the medial wall. So also you want to be aware to not excessively retract, because sometimes excessively retracting could cut through either the posterior or anterior walls. With early postoperative fractures, this is associated with aseptic loosening or early migration, and sometimes that could be related to the poor design of the cup, or some of the cobalt chrome cups have been seen to have some early aseptic loosening, and that's why titanium cups have become super popular nowadays. Trauma can also cause early postoperative fractures, or more importantly, the vast majority of this early postoperative fractures are actually missed intraoperative fractures. Like, when people are putting cups in, not noticing these fractures occurring intraoperatively, and in some cases not putting screws in intraoperatively, that could lead to this early postoperative fractures. Late postoperative fractures are usually related to osteolysis, which thankfully we are not seeing much of those more recently, because the vast majority of the implants that are put in now are late generation polyethylene, like highly cross-linked ultramolecular weight polyethylene. We're not seeing a lot of osteolysis with that. But for older implants that were put in several years ago, maybe a decade or more ago, there's still some of those conventional polys or older generation of polyethylene that are causing significant osteolysis and maybe wear, and this could lead to late loosening and eventual fractures around the acetabular component. Also, trauma could cause late postoperative fractures. Just some examples of osteolysis and some late fractures associated with acetabular components. And just another visual illustration of a late loosening due to osteolysis and eventual failure of the acetabular cup. Once again, we are just dividing the risk factors between the for intraoperative versus early postoperative and late postoperative fractures. We've gone over the vast majority of this already, and in the interest of time, we will move on to discuss how to diagnose these fractures. So with intraoperative fractures, you always want to maintain a high index of suspicion for fractures, particularly if after placing your cup, you still see significant movement of the cup. If necessary, you want to remove that cup, reassess the acetabular cup to make sure that you don't have a significant fracture. And if you do see a fracture, do not ignore it. Make sure that if you have the ability to, if that cup is stable, put some screws in different zones so that you have some stability of that cup. Don't just ignore the fractures and assume that your cup is going to be fine, because those are the cups that eventually lead to early postoperative fractures or eventually migrate and need a revision later on. With postoperative fractures, you have a plain radiograph is certainly helpful because at this point you don't have the benefit of being intra-op and reviewing and looking at the bone directly. You need to get serial radiographs to make sure that you're comparing the immediate postoperative x-rays with the new x-rays that you have. Make sure you get not just the AP pelvis, but Judet views, oblique views and Judet views of the pelvis, so that you can really see the posterior column, the anterior wall and posterior wall, and be able to assess if there are significant fractures. Advanced imaging is usually not necessary, but if you do need to, get a CT scan with some metal artifact reduction and see if you can actually see the fracture lines. With intraoperative fractures, how do you classify them? Well, one of the more popular classification is the Della Valle classification, which talks about a type 1 being one that occurs during surgery with cup insertion, intraoperative, and type 2 being the types of intraoperative fractures that occurs during cup removal. So with type 1s, you have A, B, and C, which A talks about the non-displaced and stable intraoperative implant. And this just helps you to kind of determine how to treat them. With type 1A, non-displaced and stable implant, you could just put some screws in and forget about it. You don't have to worry about it. With B, the displaced fracture intraoperatively that you can see, you probably need to take that cup out, stabilize the fracture, either by fixing the fracture and putting your new cup in, or putting a new cup in with multiple O's and using the cup as an internal plate to fix the fracture and fix the different parts of the displaced fracture through the O's of the cup. That's another way to diagnose that. And type C, 1C, is really the one that was a fracture that occurred intraoperatively, but only was diagnosed postoperatively. Unfortunately, those usually need you to take them back and then fix the fracture either with the cup or fix the fracture separately and then place the cup. Once again, just type 2 occurs at the time of component removal. And with that, you want to, if there's less than 50% of acetabular bone loss, we call that type 2A. If there's greater than 50% acetabular bone loss, that is type 2B. With intraoperative fractures, you could just you could just treat them with observation alone if it's a type 2A. I mean, type 1A, sorry, Della Valle type 1A, which is just, if you evaluate the cup and you found it to be rock solid and stable, then you could just put some screws, stabilize the cup, and have that patient have some protected weight bearing for about 6 to 12 weeks after surgery. In some cases, if you feel very comfortable, you can actually have them weight bearing. And usually those patients do very well. But if you're concerned at all about the stability of your cup or the stability of the fracture, then you should definitely consider protecting the patient's weight bearing. But for the simple posterior wall fracture or just some rim fractures that does not extend through the column, you could just make them weight bearing as tolerated, as far as you feel comfortable with your cup stability and as far as you have some screws in. With intraoperative fractures that are unstable, then you probably want to consider putting screws or fixing and then placing your cup with screws. That's what we talked about earlier when I was just talking about the type 1, B, and C. And usually what you want to do is when you check this fracture, if you feel like it's unstable and you're able to put screws in multiple zones, then you can do that. If you need to, take the cup out and go to a bigger cup to give you a little more stability, then you can certainly do that. If the posterior column is compromised, you absolutely must consider actually doing a fixation of the fracture and then revising and then placing another cup to give you the most stable construct. If the posterior column is compromised and you just assume that you can just put screws in, particularly in just one zone, you may be putting that cup, that fracture at risk of further displacing, and that cup at risk of losing fixation over time. Postoperatively, for this intraoperative fractures that are unstable, you probably want to protect the weight bearing for about 6 to 12 weeks, and definitely follow this fractures closely over that period of time. An example of an unstable fracture there that was fixed and then treated with a revision. How do you manage the intraoperative fractures? This another unstable fracture that was displaced, fixed, and then with placement of cup. And if you notice there's fixation both in the superior hemipelvis and inferior hemipelvis. This is how you maintain good fixation and give your cup the best chance of doing well. Just a quick small case series with 13 fractures by Sharkey et al., where they treated these fractures, and those were the outcomes there. With the early fractures, there's different case series that have looked into this, and your options usually are to revise them into either a cup cage construct, a jumbo cup with or without pelvic plating, or just percutaneous fixation around the stable implant if you do have a stable implant. Or sometimes you could just treat the fracture. There are different ways to approach this, but this is outside of the scope of this particular talk, so we'll just move right on. In all cases of early fracture, how do you manage them? Well, you want to make sure that you're protecting the weight bearing as much as possible, particularly if the cup is still stable or relatively stable. If the cup is not stable, then you probably want to just go ahead and revise that particular construct. But if the cup is stable, you probably could watch that over time, protect the patient's weight bearing. Or in this particular example that you see here, this patient actually needed a percutaneous screw to fix that fracture, and this patient was able to heal that fracture over time. With late fracture, just like I mentioned over time, this is usually associated with vasculitis or stress shielding, and which we don't see much of nowadays, at least in the US. But when this happens, usually you need to fix. This will most likely need revision surgery, and usually we need it would be associated with some significant bone loss. So you got to be ready to graft or augment the lytic areas, either with trabecular metal, or in low resource settings, you may need to use femoral head, allografts, or other type of bony allografts to recreate the pelvis and reconstruct the acetabulum. You may, in some situations, you may also want to stage the procedures, going first, try to fix the fracture, let the bony and recreate the pelvis as much as you can, and then come back and then do your reconstruction at a later date. But the vast majority of the time, we are able to just go in and fix these fractures in one surgery. in place and reconstruct the hip in one surgery. With pelvic discontinuity, where you have this complete dissociation of the superior hemipelvis from the inferior hemipelvis, there are no great solutions to this, but there are multiple ways that you can approach a pelvic discontinuity case. All those are listed on the page there. And I have certainly used jumbo cups. I've used cup cage constructs. I've used triflange prostheses or cages. They all have their pros and cons, and those are actually we could discuss all of these options for the next hour or so. In the interest of time, I just wanted to list those there as options for pelvic discontinuity, and this but this are outside of the scope of this particular talk. Just some illustration here for an example of a pelvic discontinuity case that needed significant reconstruction. So let's move right on to the femoral periprosthetic fractures. Once again, we will divide this into intraoperative, early postoperative, and late postop, just like we did with the acetabulum. With the early postoperative femoral periprosthetic fractures, this obviously on the rise because we are doing more and more cementless implants, and there's a desire to get the best press fit, so to minimize the risk of subsidence. And with this, you see some at Rush. This was looked at, and this is a paper from 2013 where they looked at over 5,000 total hip replacements and saw a 0.6% incidence of early postoperative fractures. 21 of them were Vancouver B2 fractures, and we'll go into what that means later for those that do not know. And this early fractures were associated with increasing age. So the higher the advanced age definitely put patient at risk of these fractures. Female sex put patients at risk of these fractures. Flat wedge taper, like single wedge taper, cementless stems, put patients at risk of these fractures, and other conditions like dysplasia, where there's a little bit of difficulty with exposure or abnormal version or excessive version. And just remember, in some patients, the best option is still a cemented femoral component, particularly in older patients with capacious femoral canals or Dorsey femurs. You still probably want to consider doing a cemented total hip in those patients. However, when you are doing a cemented total hip, you want to make cementless total hip rather. You want to make sure that you have an appropriate exposure so that you are not putting yourself at risk of fractures. Certainly, with the smaller incisions, minimally invasive exposures, you may put yourself at higher risk of causing a fracture, because you don't have good enough exposure. And you have to make sure that you stop hitting the broach when it's not advancing. So be very careful if the implant goes past the broach. If you broach to a certain level and then you're inserting your final implant and your implant starts flying into the femur, I have a very high index of suspicion that there may be a fracture. Take that implant out, examine your femur, and make sure that there's no fracture. And if you do see a fracture, don't assume that the fracture is just at the neck. Probe that fracture all the way down to the distal extent of the fracture to make sure the fracture does not extend past the trochanteric ridge. Because if that is the case, if the fracture extends past the trochanteric ridge, then the treatment is going to be different. If the fracture is just right at the neck and does not extend past, you could just take the implant out, put a cable replace the implant and make sure it's stable. But if it extends further down, you want to further, explore that wound, open the incision a little further, see the distant extent of the fracture, fix that, and you may actually need to put an implant that has distal fixation versus proximal fixation. We'll go over this in more details very shortly. Just showing you some of the areas where you could get intraoperative fractures. It's going to be really important to look at the medial calca and also look at the shoulder of the broach or implant to assess this fractures. Also, during the dislocation process, particularly the first time you dislocating a hip, that is when you are highest risk of causing a fracture. So you want to make sure that you're careful during that initial dislocation process. And if you're doing a conversion surgery where you converting a hip that was previously operated on to a total hip replacement, you want to first dislocate that hip, relocate the hip, and then take out your previous implant before you now dislocate again, do your femoral neck cut, and move forward with the surgery. The reason is because if you don't do that first dislocation and decide to remove the implant first, with all the stress rises that's been caused by the implant, and then you try to dislocate, then you could put that particular femur at significant risk of fractures. So be very, very careful with that. That first dislocation is associated with the highest torsional stress, okay? And then with these cases, you also have to be beware of the very stiff hip. With revision procedures, with second stage reimplants, all of this put you at higher risk of femoral fracture. Also, if you put in a distal fitting implant, make sure that you're able to advance the implant in. And this actually goes for any cementless implant. Make sure you advance the implant with your hand for as far as the implant can go before you start to impact with your mallet. That's going to always be very important. And with intraoperative fractures, once you notice them, just like I mentioned earlier, one of the first options, particularly if the fracture is only just in the neck and does not extend past the trochanteric ridge, you just take the stem out, fix the fracture with a cable, reinsert the stem, make sure it's stable, and you're all set. You can make that patient weight bearing as tolerated. If you do not notice that the fracture goes past the trochanteric ridge, this is what can happen. You could eventually then develop essentially a fracture postoperatively that extends further down as the patient starts to put weight on the leg. So you want to make sure that you fully examine that fracture, make sure it doesn't go past the trochanteric ridge. And then the other option, if you do notice a fracture that extends further down, get down to that fracture, secure the fracture or fix the fracture, and then place your stem, hopefully with a stem that has distal fixation, not just proximal or metaphyseal fixation. And what happens if you have an early post-op fracture, which usually is a missed intraoperative fracture that just happened early postoperatively? Obviously, in those cases, you need to take them out and just put in a distal fitting stem in addition to fixing the fracture. And with late postoperative fractures, the classification is really popularized to determine how to treat these fractures is the Vancouver classification, and usually it classifies this fracture based on the site of the fracture, the stability of the implant, and the quality of the surrounding bone stock. The Vancouver classification is classified into Vancouver A, Vancouver B1, B2, B3, and Vancouver C. With A, the fracture is the fracture of either the trochanter, pretty much, of either the greater trochanter or the lesser trochanter. If it's happening late, it's usually associated with osteolysis or some, bone lesion that causes or osteoporosis that cause the greater trochanter or the lesser trochanter to fracture off. And with this, if the greater trochanter is minimally displaced, you could potentially just watch it and not do anything if the patient is doing okay. However, if it's significantly displaced, you probably need some rigid fixation, either with a trochanteric claw like that or with a trochanteric plate. And obviously, you want to take away the source of osteolysis. So in those cases, you probably want to revise the head aligner and replace that cup with, replace that aligner with a new generation liner that is going to not cause significant wear or associated osteolysis. Type B1 is a fracture around the prosthesis, but it's got a well-fixed stem. These are very rare. So if you think you're looking at a B1, be very careful that you are absolutely looking at a B1 fracture, because a lot of people think it's a B1, but it's actually a B2. One of the easy ways to know if it's a true B1 is to compare serial images and see the positioning of the femoral implant relative to the femur, and to make sure that the implant positioning is unchanged and there are no interval changes. If that is the case, then you could just treat the fracture just like any other femoral fracture. You can fix with a plate with cables and screws, just like you would fix any other fracture, and just completely ignore the femoral component. With B2 fractures, which are the most common fractures, the stem is actually loose, but the bone stock is fantastic, it's still good, and the proximal femur. So stem is loose, bone stock is good. This needs to be revised to a revision implant. In this particular example that you see on screen, you see a Wagner type stem used to revise this Vancouver B2 fracture with some cables and with preservation of the cup, since the cup is there's no issues with the cup. In this particular cases, I still changed the head and the liner. So remember that in these cases, if you're still going in, you still want to try your best to change the liner and the head. And just remember that the distal tip of the stem must bypass the distal extent of the fracture by at least 2 cortical diameter. And you see that here, where there's enough fixation in that isthmus to allow for the fracture to be stable. If you do not do that, then you put that patient at risk of failing because there's not enough fixation in the isthmus of that patient. If you do not revise a loose stem, this is what happens. If you decide to fix the Vancouver B2 or B3 fracture, this is what potentially happens. And also, do not be afraid to use an extended trochanteric osteotomy to further expose particularly a cemented stem. Yeah, use it to your benefit, and expose, use it for cement removal, use it for component insertion or removal. So if you're going to do an ETL, just make sure that you put in a prophylactic cycloche cable distal to the most distal extent of that ETO, so that you can make sure not to further propagate the fracture distally when you're trying to put your cup in, put your stem in rather. So this is a very important point, that if you're fixing these fractures with or without an osteotomy, just make sure that before you start to ream for your distal stem, that you are putting a cycloge wire distal to the most distal extent of the fracture, so that when you start to prep the isthmus, that you do not cause an additional fracture and then completely lose your isthmus. All right. With type 3 fractures, there's poor bone stock, and there's loosening of the stem. So you have a fracture, you have poor bone stock, and you have a loose stem. In these cases, I mean, in Europe, people still love to, extract their stem, do some impaction grafting and things of that nature, and then place a stem in there. In the US, for the most part, we are still treating these patients with mostly modular taper revision stems. In some cases, you may need to go to a proximal femoral allograft, or even potentially a proximal femoral replacement. That's an example of what a proximal femoral allograft and a proximal femoral replacement looks like. And with type C femurs, these are fractures. I mean, with type C fractures, these are fractures that are occurring just distal to the stem. They have nothing to do with the stem, and you literally could just treat them like any other fracture of the distal or mid shaft of the femur. Just treat them with either with plates, and if they distal enough, if you could treat them with a combination of nails and plates, or intramedullary nails and plates. But you certainly could treat these patients. Just make sure that you overlap the plate with the stem, so that you don't have stress risers in between. So concluding, early periprosthetic fracture is a serious complication of total hip replacements. There's a high rate of further complication if you're not very careful with these cases, and there's certainly a high rate of further repeat operations. You want to make sure that you're very careful during femoral preparations, particularly in elderly females. With high-risk patients, during your index total hip replacements, you probably want to consider doing cemented femurs, of cemented femoral component versus cementless femoral component, and at least have a diaphyseal engaging femoral stem as a backup, just in case you have a fracture with a metaphyseal engaging stem. And with late fractures, it's important to differentiate between a B1 and B2 fracture, because if you treat a B2 fracture as you would treat a B1 fracture, you setting that patient up for failure and for a revision down the road. And don't be afraid to use an extended trochanteric osteotomy to address difficult B2 fractures, and use and get some distal fixation with the modular stem with your B2 or B3 fractures. And once again, it's important to differentiate between a B1 and B2 fracture, and don't be afraid to use your extended trochanteric osteotomy. Thank you, and we'll take questions on the day of this presentation.